here to take a new look at an old problem. And that's why we have two of us here. I'm old and wise, and Lauren is new and inventive. So what is the problem? The problem is we are spending a huge amount of money on healthcare, and our outcomes are just not that good. We spend more than any other country of the industrialized countries, almost twice as much, on healthcare services, doctors, hospitals, et cetera. And yet our health outcomes, our maternal mortality rate is much higher. Our life expectancy is lower. We have more diabetes, more heart disease, more disability. It goes on and on. How could this be? It's really a paradox. We're spending so much, getting so little. And it's been this way for a long time. It's an old problem. I've been working in and studying healthcare for 30 years now. And I remember the 80s, everybody was all fussed up. We're spending so much money, no one else is. So we completely overhauled the way hospitals were reimbursed, completely changed the way doctors were paid. And did it make a difference? Didn't make that much difference. Then in the 90s, we said, great new model, HMOs, everybody get into HMOs, enrollment soared, and then end of the 90s, beginning of 2000s, they didn't really seem to be a panacea, and people disenrolled. Then the last 10 years, we've been really thinking about how do we measure quality? How do we report quality? How do we measure patient experience? Can we make it better? Can we incentivize people to have better, higher quality healthcare and a better experience for the patient? And guess what? The data haven't changed. This is an old problem, and we are stuck in it.
It's a really interesting history, Betsy. Maybe especially because you lived through it. But maybe we can tell them something about the modern day. Why don't you tell them about Joe?
Okay, let me talk about Joe. Joe is a story of a 28-year-old man who has diabetes, and he's had diabetes since he was a child. One of the side effects of diabetes is nerve endings, start to suffer, and there are foot problems with diabetes. And so unfortunately, when we met Joe, in the last year, he had really developed gangrene on 2 toes on his feet. And it's a true story, and he had to have them amputated. Now, what's tough about the story of Joe is he doesn't really have steady work, and he doesn't have a permanent house to live in. So he's always going house to house. And he has recently been staying in a boarded-up house with his friend. The only way you can get in the boarded-up house is through a marshland. It's wet in the back. His doctors have told him the one thing you really need to do is keep your feet dry. You got to eat well and keep taking your insulin, but really you have to keep your feet dry. He's just having a really hard time doing this. He can't get enough money to really eat well, and he hasn't got a good pair of shoes. His shoes, the soles have holes in them. So really he just keeps getting his feet wet and inadequate care for himself. So what do you think happens? Now the doctors told him, you're going to have 4 toes removed. And if things don't turn around for you immediately, you're probably going to have a below-knee amputation. When you add up all the medical care this person will have, it's like $30,000 in a year. And he's not doing well. He's getting the medical care. He's got insulin. He's taking care of himself that way. But think about it. A pair of shoes would cost $50.
Is this not so classic? I mean, this is so American, right? We have this view that health and healthcare are one and the same. We think that health is something that we can secure individually through a relationship with a top-notch, right-priced provider. And this makes sense based on our history, based on our values, even based on how we've structured our economy. And there have been some real benefits to this, right? If you need a knee replacement, there's nowhere else in the world you would rather be. We do more of them, we do them quickly, we do them efficiently. Same thing, you need a kidney transplant, this is where you want to be. You need an MRI, we can schedule that the next day. So there's been benefit. But there have also been some really enduring challenges. When you look across the OECD, these are the industrialized countries, the Organization for Economic Cooperation and Development, and you look at some of the health metrics that they really value, we're at or near the bottom of the 34 countries. When you look at maternal mortality, 25th. When you look at life expectancy, 26th. When you look at low birth weight infants in the United States, we rank 28th. So, I mean, this is an issue. And it's really important to think about this as an issue that affects all of us. A lot of times we'll tell the Joe story, And someone will then come back and say, you're a pack of bleeding heart liberals. You belong at Yale and Harvard, but that's not the real world. That's just not my issue. But when you look very narrowly at Americans who are relatively advantaged, they're insured, they're educated, they're employed, that group still fares worse than their European counterparts, those in Sweden and Denmark and England. And so this really seems to suggest that there's something bigger going on here. It's not just about poverty. There's something larger about the American context, which seems to be really damaging to our health.
So let's go back and look at the data. We know most people have seen a slide like this sometime, but let's just reorient for a moment. The y-axis is the percentage of a country's GDP that's spent on healthcare, doctors, insurance, hospitals, et cetera. And along the x-axis, we've lined up all of the countries in the OECD. And what do we see here? The United States is spending 18% of its GDP on healthcare. It swamps the rest of the OECD. And if we look at sort of what the average country in OECD spends on healthcare, it's about 10% of their GDP. Now, the question we had to ask ourselves is this really a complete picture? Thinking about Joe's life, is this a complete picture of what we're doing to get a healthy population? We got to go back to the basics, back to the fundamentals of what determines health. And in fact, genetics determines about 20% of our health. Healthcare, the access to doctors and medicine, et cetera, determines about 20% of our health. But what's in the middle there, the largest part, are the social, environmental, and behavioral factors. The things, think about Joe, back to Joe. The shoes, the housing, the employment, the right food. These are the major determinants of health. And so if that's the case, and we're only looking at healthcare expenditures, shouldn't we be thinking about what else we're doing to actually create health? Maybe we should look at what people are spending on social services. Happily, the OECD data collects exactly what people are spending in a whole host of social services, including employment programs, housing and rent subsidies, nutritional support, family assistance, and a whole set of other social services that exclude the health benefits. So what would it be like if we could take our data on health spending and add to it, take this chart and add to it what every country is spending on these social services? What would we find out? We could call this the total investment in health, because it would include both of these sets. This is what it looks like. We're not the high spender. The United States is just middling.
And that's fairly interesting. I mean, it may surprise you, given how prominent that first graph is, where the US spending is so high, to think, okay, well, if we take a broader look at the spending accounts, we're only in the middle. But what I told you before is we rank 25th, 26th, 28th out of 34. That's not the middle. That's the bottom. So we wondered, is there something else going on here that is even beyond that kind of distribution? It seems like when you just look at the middling data, there's still a paradox. When we pushed a little further, we found something else that was really telling, and it was about the way that each country allocates spending between the health and the social services. And so you see here a graph of the ratio of social to health spending in all 34 of those countries. Now what you see is that the US is the lowest, the far right. We have the smallest ratio out of all the industrialized countries. And so this is really striking, right? Because generally we think we're swamping everyone. We're investing so much. And yet here we see ourselves turning up as really a very small bar. So the question was, does this matter? I mean, it's an interesting finding intellectually, right? But, I'll summarize the graph first. To translate it into English, in the US, for every $1 we spend in healthcare, we spend an additional 90 cents on social services. And this is data culled over 10 years. In the OECD, that ratio is $1 invested in healthcare is $2 invested in social service spending. So this is a really big difference that is not being talked about generally when we present the health spending data alone. So now the question is, does it matter? Or is this really just an intellectual exercise that's interesting to academics but bears no relevance on real Americans?
Well, this is an intellectual exercise that's interesting to academics, but it also really matters. A resounding yes is the answer to this. Countries with a higher social to health spending ratios have statistically better health outcomes. And this is true for they have lower infant mortality, they have fewer low birth weight babies, they have less premature death, and they have longer life expectancy. And a couple other facts about this research is that even if you take a look at the health spending, in addition to the ratio, the health spending effect is quite small, and the ratio is strong, above and beyond just what we spend on health. And then in addition, even if the United States is taken out of all of the analysis, this is true across the OECD as well. Let's go back. It makes sense. If we remember the stories of what this middle group really does, we remember Joe, we think about it in our own lives, where we live, how we eat, when we exercise, these things matter. And what a country is spending on these things is really a proxy for how much attention a country, a nation, will really direct towards these determinants, which we know are the most powerful for the health of the population. Paradox unraveled.
Before we unravel the paradox fully, let's make sure everyone's with us. It's been a lot of charts and graphs. There are 3 key insights from all of this information. The first is that the U.S. is not necessarily as high a spender or as high an investor in health as you may have walked in the door thinking today. The second is that the U.S. has a really distinct allocation pattern between these 2 buckets. And the third is that the way countries, all industrialized countries, allocate resources between those 2 buckets really matters for health outcomes. More broadly speaking, I think what we can take away from this analysis is that health does not equal health care. This is a real logical fallacy that's been incredibly damning over the past 30 years as we attempted multiple reforms. What we find is that it's a really expensive approach, and it's not a very effective approach. As we look to the future, however, I'm very optimistic. I think now that we have this data, we can see the real impact and the interdependency between the healthcare spending and the social service spending. And all together, we can do a better job.
Yeah. I really hate to be the old curmudgeon on this, but how?
Well, there are a few ways. We could spend more on social services. We could make sure that Joe had everything he needed. He could have housing. He could have shoes. We could really bolster that whole sector of our economy. We've been to Scandinavia. It's wonderful there.
That is Scandinavia. I love it. I love it. I just, raising taxes, really supporting all these services that some will argue might not really be as efficient. I just don't know. In this political economy, are we really saying raise taxes so we can buy Joe shoes?
Okay, here's another idea. We could just look at that total investment in health, the healthcare and the social, and we could not spend more, but we could move money from the healthcare service into the social service. And this is really, you could imagine it could happen. We know there's a lot of waste in that industry, and medicalization has really run up costs. Could be done.
Okay, let's go back to the real world here. You're going to take the industry that is the largest in the globe. It's 18% of the American GDP. And you're going to say, well, we're just going to take money away from you, and we're going to put it over in public housing and food stamps and education. I don't know. Again, I love the vision, but I just think it may not work. It may not be realistic that we could make that happen. And it is an important part of our economy. 18%, a lot of jobs, a lot of profit, a lot of good stuff coming from that. We need that part of our economy.
Okay, a third idea. What if we went back to the healthcare sector, this huge sector? It's well-funded. It's highly professionalized. We know it does things well. And what if we worked with that sector to broaden its mandate? this could have three real forms. First, it would require all of us to support them in that and to really dissociate these ideas of healthcare and health. Second, we could really help them and create an environment where they could partner with people in the social service sector. And third, we could reward them. We could incentivize them for attending to these social, behavioral, and environmental determinants of health that we now know is so powerful.
It's a good idea. That's an idea worth spreading.